You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that had, has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoy the podcast, please listen, subscribe, like, and share it with friends. Thank you. Hello, this is Richard Jacobs with the Future Tech and Future Tech Health Podcast. I have Dr. Mark Burhenne. We'll be talking about his book, The 8-Hour Sleep Paradox, How We're Sleeping Our Way to Fatigue. Dr. Mark is a best-selling author and a family and sleep medicine dentist who's been in private practice for about 30 years, focusing on patient-centered and preventative dental health care. He sees people from all over the world. He's got many accolades and has been around the block many times, I'm sure. So, Dr. Mark, thanks for coming.
Oh, Richard, thanks for having me on the show.
Yeah. So where did your book come from? What was the inspiration for writing it, and why is it called the 8-Hour Sleep Paradox?
As usual, it's a personal experience. How often do you hear that about authors, right? I discovered I had sleep apnea, and my wife as well. And, we were healthy, doing well, exercising. We weren't too overweight. We were functioning in a very stressful environment in Silicon Valley, both working, raising 3 kids. And then in our, let's say, mid-40s, we dropped off our first daughter to college. And of course, that put us all in the same hotel room. And I woke up with my 3 daughters throwing pillows at me going, "Dad, you sounded like a freight train last night." And I was like, "Oh, okay, well, that's interesting." I remember my parents snoring and my mom a little bit, but my dad a lot. And I thought, well, that's interesting. And, back then snoring to me it was almost funny. It was like, seeing Bambi snore in the Disney cartoon, right? Or Popeye or all those kind of things. I'm dating myself, of course. But anyway, so to make a very long story shorter, we had to navigate that whole process of fixing our sleep. And we're both healthcare professionals, and we just found it to be very frustrating, difficult to navigate, confusing for the layperson, even for us. And so that originally what prompted, I told my daughter, who helps me with our website, I said, "God, this is a frustrating process. There's so much I've learned. How do I get that out to other people?" And she said, "Well, write a book." And that's how we wrote the book together. And it was a 1-year process, a lot of research and study and personal experiences, and then trying to make that more universal for other people in other countries. And so it really was treating my sleep apnea, my wife's sleep apnea. And I have to say, I wouldn't have been able to write the book if I hadn't been able to treat my sleep apnea, because I started feeling much better. I only had mild sleep apnea, 12 interruptions per hour at night while sleeping. And, I quickly, through my treatment went quicker than my wife's. I was able to, become more alert, wake up earlier, feel better, focus longer. I was doing a lot of research and reading. What I hadn't noticed over the years is that I love reading, mostly nonfiction and research, of course.
Yeah.
But what I had noticed is that I couldn't focus as much as long. I remember, after I started sleeping better, and then next morning being able to sit down and reading for an hour straight with no interruption, no thought of, standing up or going to the refrigerator or, that kind of thing. I realized that's the way it was when I was younger. So it was great on all fronts, but I did want to share that with as many people as possible and well beyond, my patients and my practice, my private practice.
Yeah, no, my family's had experience with it too. My dad had and probably still has it. Just, I don't know, doesn't want to do anything about it. Um, I'm sure I had it on my back, and doesn't seem like it on my sides. But once I lost some weight, then it seemed to get better. But yeah, I would read and fall asleep. I couldn't read more than like a page, and I would just constantly fall asleep doing that. So I'm
Right.
sure people have suffered many more things from sleep apnea. It's pretty
Oh,
pervasive. It
yeah.
seems. Do you any stats
Oh,
on
yeah.
the
Oh, yeah.
percentage of
Goes
people that
well
have it
beyond
at
that.
certain ages?
It's probably, it depends on who you talk to. And so generally the numbers are 19, 20%. In my practice, it's 30%. I mean, and I've literally, out of 5,000 patients, I've looked at that number and studied it. And I'm not sure why it's a little bit higher there. I think it's just because I'm better at diagnosing it. I see it earlier, perhaps. Dentists can see sleep apnea decades before a physician can, because we look at different things. We've been trained, and well, it's the oral signs and symptoms that alert us to that, and so it's
So
very
like what?
prevalent.
Yeah, what do you
Um,
see that a physician wouldn't
yeah,
see? What happens in the mouth?
yeah, it's good. It's
Is
a
it
good
that you're a
question.
mouth breather, and what happens?
It's a I have a list that is in the book. Actually, the list has gotten longer. That a checklist that I go through, and it's got at least 50, 60 items on it. Scalloped tongue. The tongue sits high in the floor of the mouth. A narrow arch. In other words, the roundness of your lower arch, upper arch of teeth is narrow or V-shaped. The height of the palate, the narrowness of the palate, position of the tongue tie, um, tonsils swollen, but mostly in kids. We see a lot of kids not breathing well and suffering, and their tonsils and adenoids are very large, enlarged. Facial structure, that's a big one. When I go to a cocktail party, again, I'm dating myself. When I see people out in the open, it's so evident to me who is suffering, just based on the facial type, profile, frontal view, side view, development of the lower jaw. I mean, and there are other factors. And of course, I throw in all the what the medical doctors look for, all the comorbidities of sleep apnea, and that's my second list. I've separated it into two. And then, if I start seeing all those dental warnings of sleep apnea, and then I see, oh my God, this patient's going to the bathroom a lot in the middle of the night. That's nocturia. He's got high blood pressure. He has AFib. He complains of daytime sleepiness, and he's depressed. I mean, then I throw in all the other medical stuff, and within 15, 20 minutes of conversing with a new patient, it's pretty clear, even to what degree the sleep apnea is. And that's when I don't diagnose sleep apnea. Dentists aren't allowed to do that, but I screen for it. That's when I make the referral. And I make the referral to a sleep specialist, an MD. I work across the street from one. If they're not part of that medical system, then I make sure that they're on their way, and usually they've read the book and they understand the process, and that's where it gets complicated. That's where you start getting pushback, although that seems to be a little bit less than it was when I wrote the book 3-4 years ago. So yeah, there are lots of things in the mouth that make it clear to me, and even outside of the mouth, facial structure, as I mentioned, that make it clear to me that this person has an issue. Chapped lips, the shape of the nose, sniffling. I mean, it goes on and on. And I've been around it for so
Okay.
long, and yeah, I can make a quick kind of assumption of that person's ability to breathe within usually minutes.
What about the world of remedies? Seems like there's two big camps: there's the CPAP camp, and then the oral appliance jaw advancement camp.
Right. Yeah, those are the two big ones. Surgery's kind of behind all that. We can talk about that. So APAPs, CPAPs, it's a positive pressure machine. Everyone fears that machine. They've heard about it. They've seen a friend or a loved one or a family member use it, travel with it, or they've seen them use it and then throw it away or give it away. It's a little box with a tube that somehow you connect your airway through the nose, through the mouth. It's something that you have to strap to your face and head. And it basically blows you up like a balloon. It prevents the airway from collapsing. There's enough positive pressure being pushed down inside of your esophagus, towards the lungs and past the airway, that airway will not collapse, and you will not wake up because your body doesn't think you're suffocating. The oral appliance, which has been around, well, the APAP, CPAP. APAP is an automatic CPAP. CPAP is the continuous pressure device. That was, I think, invented in early 60s, maybe 65. The oral appliance actually has been around a little bit longer than that, but it was more of an orthodontic device. And now it has come back into favor. For a while there, a lot of physicians and even dentists thought it was causing TMJ and that it wasn't really working. But now we have studies that support the fact that these oral appliances can be very handy, especially if the CPAP compliance is very low, which it is. About 30% of people hang in there with their CPAP after the first year. And there's usually no follow-up. It's very frustrating to see that, where they've gotten the diagnosis, they've got through it, they've got the solution, and then after a year or 6 weeks or 8 weeks, it doesn't matter, they're running for the next decade or two with nothing. So those are the two camps.
Compliance so low? What causes people to fall out?
Yeah, it is low. Oral appliance compliance. Oral appliance compliance is. It depends on here, 70s, 80%. Even I've seen as high as 90, depending on who's making them and all that. So why is it so low? Well, I mean, think about having a tube stuck to your mouth or nose and blowing air into your lungs. It dries you out. It can predispose you to, lung infections, dry mouth, higher cavity rate if you don't use the humidifier. It's bulky, it's cumbersome, it's noisy. It's noisy if you're a sleep partner. You have to get used to the noise. But they keep improving them. I always encourage people, even though I'm doing an oral appliance for the patient, I always encourage them to hang in there, keep working with it, make sure you have a great provider that, the people that dispense these machines, that they're working with them on getting the right face masks. I even make recommendations for face masks because I know what works and what doesn't work. I've seen people struggle, and I've gone on the web, and in the back of my book we have this great reference that people love. It's a URL to a kind of a users group of CPAP users, and actually they're the experts. It's not the people that dispense these units, it's not the doctors, it's not even the dentists, it's the people that are using them, that have successfully used them. And so I steer people there. I scan that late at night myself, even though I really don't wear a CPAP, but my wife did, and it's just good information. So again, cumbersome, difficult, if you don't have insurance, expensive, and it's something that you have to get used to. And a lot of people, especially if they're tired, don't have the patience to really sit down and be very detailed and analytical. And when they're tired to make this mask fit properly. The good news is that there are some great advances coming in sleep. Speaking of the future, there's a next door to me. I mean, in the valley, we've got a company that's going to scan people's faces and 3D print the mask so that they fit better. One of the problems with these masks is that they cause ulcerations and blisters. They don't fit properly. The air blows past it into your eye, dries out your eye. So that's cool. There's a big
company that's doing the 3D printing of masks.
I think it's called Carbon. And they've been doing shoes. You can scan your foot. I mean, they're going to scan just about every part of the body that has something attached to it. It could be prosthetic joints. Because I mean, let's face it, there's so much variability when you're dealing with the human body. And so it's great technology. You're also going to see a lot of, part of the problem with sleep, and I write about this in the book, is that diagnosing it is difficult. That sleep study is the threshold that I referred to earlier, because it's expensive and a lot of people don't like sleeping in some weird, strange room, and people are coming in and out and making sure everything's glued to your face and head and chest. These leads, these wires that are glued to you. I mean, I think the medical community assumes, just come in and sleep. No, people are very particular about their sleep, especially people that are very tired. They lock the door. They have maybe a lights on. Sleep is a very individual thing, and we all kind of have our little phobias about sleep. And so that's where the revolution is going to come. We're going to get, instead of a $3,000 test, sleep test that's done in some weird clinic or hospital, we're going to be barraged soon, and it's already starting, with these $100 to $300 tests that we can just slip on our finger, stick in our ear, wrap around our forehead, stick to our forehead, glued to our upper chest, little patches. I mean, that's coming. And these tests are going to be as good, if in many ways not better, than the gold standard, and that is this PSG, the polysomnography. And that will be wonderful because, Richard, there are about 80-90% of us out there that have sleep apnea that have not been diagnosed or don't even know we have it. We're driving, we're flying planes, we're surgeons, we're bus drivers. I mean, we drive our own vehicles, between 1 and 5 o'clock in the afternoon. That's when we're, people that don't sleep well are very dangerous on the road, on these two-way roads. So it would be nice. I can't wait till that wave of diagnostics come, and then everyone will be able to sleep study. So everyone will be able to get a sleep study, and everyone will be able to not only diagnose what their situation is at any age, but we'll be able to continually verify our sleep based on, if we gain weight, as we get older, sleep gets worse.
Since your bailiwick seems to be the oral appliance, let's talk about that more. So what is it doing? It's like a mouth guard. You're biting, and that advances your lower jaw. It pulls it forward. Is that how it works?
Yeah. Well, I look at it as kind of a two-stage process. When we sleep, especially on our back, but even on our side, our jaw falls backwards, and that's for a variety of reasons. Gravity. The lower jaw is very dense. The mandible is like a piece of granite. It's got the tongue attached to it. So when the muscles relax as you approach deep sleep, which they all do, except for the diaphragm and the heart, of course, the jaw falls downwards into the pillow. And with it goes the tongue, and as do the muscles of the airway. They become very flaccid and they lose their tone. And all of that contributes to an airway that when you breathe in will collapse. It will, like a balloon. When you draw air through a collapsible airway, the Bernoulli effect, it will suck itself closed. And then that could happen. You could have a collapsed airway for 30, 40, 50, even 60 seconds. And then your body thinks, oh my God, we're suffocating. We can't let this happen. And it wakes you up. And that can happen up to 70, even 100 times an hour. Imagine someone waking up. For me, it was 12 times an hour. Imagine someone waking up 12 times an hour. How would you feel? You'd be pretty frustrated and angry in the morning, anxious. You will not have rested. Your brain will not have healed. So the oral appliance basically reverses all that. First stage is you don't necessarily have to advance the device. It's an upper and lower night guard. Everyone knows what a night guard is, or a retainer. They can be very thin. They can be a little thicker. They can be thermoplastic. They can adjust to body temperature. They can have metal pieces in it. It can be all plastic or acrylic. It comes in so many different versions and forms. And then the devices are connected together via struts or bands. And when you lie down and the muscles let go of the mandible, the lower jaw, and you're relaxing and you're going into deep sleep, the jaw doesn't fall back because it's being suspended or pushed upwards with these struts or suspended by the straps. And so that's the first stage. In other words, I have a lot of patients that, they may only have 5 or 8 interruptions per hour. They're healthy, they're thin, but they want to sleep better. So what we do is we just support the jaw. We don't advance them. Those devices can be advanced, which makes it a little bit more complicated. But for those people that are borderline, all we do is give them this device. We deliver it, we take impressions, we scan their teeth. We have to adjust it maybe a few times. And then they wear this at night. And every time they go to sleep, the jaw stays where it is. It doesn't fall back. The more radical or the more classical way these things work is that we actually advance the patient. So they may have an obstruction just in a normal jaw position. And by advancing the mandible forwards or upwards, if you're lying on your back, the tongue gets out of the way, and typically you can keep that airway open without blowing a lot of air inside the patient. And then sometimes we do an oral appliance with the CPAP. That's actually one of my favorite therapies because the CPAP can be turned way down. The oral appliance doesn't need to be advanced that great. So you're taking advantage of both technologies, but you're not pushing the limits on each of those devices or technologies. And that sometimes works very well for people. So oral appliance basically is it's like a stent, or it basically keeps your arteries from collapsing in your heart, your coronary arteries. It's that kind of concept. Pretty cool.
So is it because are you biting it, or it just sits in your mouth? Like,
yeah,
you
it
have
just
to
sits in your mouth.
energy to bite it,
yeah.
Or how does it work?
No, we definitely don't want to do that, because if that was the case, then when you went to sleep, you would become paralyzed, and your muscles stop working, and so it wouldn't work. No, you snap it into place. I mean, I put mine in the dark. I think nothing of it. It's like putting on a pair of sandals, flip flops. It's just an automatic thing. It takes a second to do and maybe 2 seconds to remove, and it's very comfortable once you get used to it. I mean, most people, if they've worn a retainer or night guard, which a lot of people have, then this is very second nature. It's not a problem. For people that haven't worn anything in their mouth and they're breathing through their mouth, they can't breathe through their nose, they have a gag reflex, it can be difficult at first because of the bulk and the material that's in there. But it's a very relaxed, passive thing. Once you snap it in, your upper and lower arches have snapped into these little night guards, these little U-shaped devices, and you've got the strut there, and you just basically let go of your face. You just kind of relax, and the jaw does not fall back. So it's a very passive state.
Well, can you breathe through your mouth with these mouth guard pieces, or do you have to breathe through your nose?
Well, that's a really good question, actually. Very few people ask that. The short answer is we want people to breathe through the nose, but let me explain. So you can make a device that is open in front, that has a little cannula or an airway or a tube, or the patient's mouth will fall open and they can breathe through their mouth, yes. And that is a necessity because I have a lot of patients that can't breathe through their nose. However, for the patients that can't breathe through their nose, I'm actively getting them to fix that because a CPAP or an oral appliance or both, the efficacy of those therapies, those modalities are much higher if the patient can breathe through their nose. So I ask patients if they can breathe through the nose to tape their lips shut. First, they put their oral appliance in, their jaw slightly forward or it's being supported. Then, and this is what I do, then I tape my tape my lips closed. Again, very passively. If I were to open, the tape would peel off. And that forces me to breathe through my nose, which actually, and I can measure this using wearables. I have a Oura ring, but other devices pick up on this too, especially the pulse oxes, the ones that measure oxygen in your blood. I can literally see the difference between my mouth being taped all night long and not being taped. Even though I'm a good nose breather, my mouth will inevitably fall open at night. I have my device in there, and my breathing rate and my respiratory rate and my resting heart rate will slightly go up. And that's not what you want when you're, sleeping. You want all those stats to drop. You want your heart rate variability to go up. You want your body temperature to drop. So it's breathing through your nose is crucial, whether or not you wear a device, whether or not you have an oral appliance or a CPAP. But your question is interesting because a lot of people, they need the device. It will help them, the oral appliance, but their nose is blocked. Well, temporarily, I would say that's okay. Let's get you the device. Let's get you breathing with your mouth open. But to really optimize things, you have to refer that patient to an ear, nose, and throat and get them able to breathe through the nose. It may just be myofunctional therapy. It could be many things, but typically it's a surgery that has to be done. So you can talk with these things in place. It's kind of like the British bulldog kind of talk. And you can take medication. You can drink water, depending on the device. Some are kind of locked in front. I don't like those devices where you can't move your mandible. You're kind of locked into position. You can yawn. You can yell out. You can talk in your sleep with these devices, and you can breathe through your mouth if you want.
Over time, if they're advancing your jaw or even holding it in place, wouldn't that change the structure of your face as your muscles are put in a different position for, 8 hours a day or a night?
Yeah, so that is both the CPAP and the oral appliance have side effects. It wouldn't necessarily change the shape of your face unless you had like a very retrognathic face. Again, remember, I think I told you earlier that this device was around much earlier than the CPAP, but it was around as an orthodontic device. It was designed to pull the jaw forward and downwards to help the facial development of a child. So again, an orthodontic device. It was called the Herbst appliance. What it does is it could change your bite. And sometimes they can improve it. I had a class 2 bite, which is slightly retrognathic, receded, chin, and it actually improved my profile. Sometimes patients will wake up with their bite will be off in the morning. What we're essentially doing is, and one thing I didn't mention earlier is that most people, one of the early signs, dental signs of sleep apnea is grinding or bruxism. It's not clearly understood, and at least in 50, 60% of the cases, patients, I think it's greater than that, but Patients that grind their teeth, brux their teeth, sleep bruxism, it's called now, grinding at night. That's a sign that they're struggling for air at night and their airway is collapsing. Those people have also myofascial issues, morning headaches, their muscles of mastication are worn out, they can't keep their mouth open for a long period of time at the dentist because they're cramping, the muscles are so tired from grinding all night. These are all signs that we look for. Those people, they can't, the device is undoing decades of grinding. So, you can't get into that tight position where the masseter muscle closes tightly because the device has you more forward. So we're undoing a lot of, hypertrophy, adhesions in the muscle. And it's almost like you're stretching out your calf muscle kind of thing. So that it doesn't change facial structure, but it does change the mechanics of chewing for a short period of time in the morning. But if you wear this thing long enough, and the majority of us that do wear these devices, once we're used to it, we basically have two positions. We go back and forth between the two positions. That forward position at night, in the morning, within minutes, we're back to our centric or seated position where our teeth meet properly and we can chew. So, but some people don't. Some people stay in that zone where, they love their device, they're addicted to it, they can't sleep without it, they won't wear an APAP or CPAP, and then their bite is kind of off until noon or 1 or even 2 o'clock. And I went through that in the early phases of wearing my device, and it doesn't happen to me anymore. Occasionally it will. If I sleep more than 7 or 8 hours, I don't normally sleep. I usually sleep under 7 hours. And so that's a problem. But the good news with that, I find, and this is just a personal reflection on it, is that with intermittent fasting, I try and narrow my eating window now. So I don't eat till noon anyway. So it works. It's fine. I don't need to be able to have a tight bite until noon. So I eat lunch, big lunch, light dinner before 6, and I'm done. So that works in that regard. It doesn't solve the problem for everyone, of course, but yeah, you can. There are muscular changes, some bite changes, sometimes permanent, nothing serious. And the other thing that people ask about is TMJ. What if I have TMJ, TMD? That's clicking and pain in the joint, dislocate, kind of a damage to the meniscus, the pad that allows us to move properly, that jaw joint, and dislocate the jaw. It's the only jaw in the body where we can literally just pop it out and move it forward. That's why we're able to keep it and slide it forwards for sleep. That's a complicated mechanism, and often it can go wrong. Most of the time it will go wrong if someone's grinding their whole life because of sleep apnea. And so in a nutshell, if you have TMJ, TMD, don't not think that you can get an oral appliance. Sometimes, actually often, an oral appliance will undo that and take away a lot of the pain that the patient's experiencing with TMJ.
So, when patients come to see you, are they having sleep problems and therefore they come to see you? I mean, do people think a dentist can help them with sleep problems or only a sleep doctor? So, or do people come to you for normal checkups and you say, wait a minute, this is going on?
Yeah. Well, I mean, back in the early days, that wasn't the case. Now, I mean, I have people come from all over the world. I have physicians that come see me, that in their backyard, in their own university, they've got a sleep clinic. And so I'm handling a lot of very difficult cases that haven't responded. And so I get those patients now, and that's a lot of fun, very challenging, and makes it very interesting. But the bulk of my practice, I'm still a general dentist. Everyone gets screened. Last month, actually the last 2 months, we had over 30 new patients. Every single one of those patients, even the 1 and 2-year-olds and the 4-year-olds and the 8-year-olds, they all get screened for sleep apnea. That's just the way I've set up my practice because, 10, 12 years ago, I realized, gosh, I can see this, I can do something about it. And I'm just shocked. Back then, I was shocked at how many people didn't know they have sleep apnea. And they're seeing their physicians. I mean, they have seen other dentists. They even know that they're tired. They've been told that they snore. But so I'm still a general dentist. People come in for a cavity, or they need a crown or root canal, and then on that day, typically when I first see them, it's like they also know that they have sleep apnea, and some of them are really bummed. And I even have patients tell me, my longtime patients, they give me a hard time. In fact, this happened last month. I got a referral of a family from another family that we've known for a while. And, they were very pleased, and we went through a lot. And of course, a lot of them had sleep apnea. And then she kind of looked at me and said, you know what, the family that referred us, they said that everyone has sleep apnea in your practice. And I laughed. My staff did too, because it's 30%. It's about 30%. It seems that way because we are very focused on this. We are screening everyone. We don't want anyone not to have a chance to fix their sleep if there's a problem. So I hope that answers the question.
Well, the question is, do people think, I better go see a dentist because I'm tired all the time and I have daytime sleepiness? Or do they think, oh, I need to go see a sleep doctor? I mean, do people just incidentally, is it pointed out incidentally by a dentist, or is it, or is it accidentally pointed out?
Yeah, it's a good question. I think back 10 years ago, that no one thought to see their dentist. I think today it's changing. A lot of dentists like me are talking about this and treating it, and we've got organizations like the American Academy of Dental Sleep Medicine, which is a group of doctors and dentists that are collaborating on this and working together as a team, which is the way it should be. But here's the thing. So people now are thinking, okay, maybe I will go see my dentist. But the important thing to remember is, who do you see? Most people in this country see their dentist twice, maybe 3 or 4 times a year. How often do you see your primary care physician? And so we have that luxury, not the luxury, but we have this great opportunity as dentists because we have loyal patients. We see them more often. We have so many opportunities to give them nutritional advice, sleep advice, kind of that overall systemic, what happens in the mouth happens in the body, oral microbiome, feeding the gut microbiome. I mean, these are all the new frontiers of functional medicine, including sleep. And we have a great opportunity here, if we're trained properly, to not take over the physicians. We're not trying to do that. But people use their dental insurance more often than they do their medical insurance. The deductibles are way lower. People wait till it's too late to see their physician sometimes, where they've been seeing their dentist on a regular basis. So instead of just drilling and filling and doing those kind of things, we really, as a profession, dentistry, we really have this great opportunity now and in the future to be so much more than just a drill and fill, kind of tooth carpenter. You've heard all those terms, right? So that's the thing. I don't know. I think patients now are seeing dentists as more of an all-rounder in terms of healthcare, especially in sleep. I think you'll see more of that with the gut microbiome, dysbiosis in the mouth. These are all new terms. Oral posture, facial development, getting our kids to grow up properly so they don't have airway issues. There's a lot more going on in dentistry, so it's very, very exciting. So I think patients are getting it, but the frustration is that not all dentists are up to speed. So the patients get frustrated. It's like, which dentist can do this? And so I see a lot of that. So
how does someone end up with a CPAP versus an oral appliance, or vice versa? I mean, is it just luck of the Irish, or like if I go and have a sleep, if I go to you and you say, oh, it looks like you have sleep apnea, you can't diagnose you, you got to go do a sleep study. I go do it. Then what? How do I get pushed to one item or another? Who makes the decision?
Yes, it's not arbitrary, and it's not up to me to make that decision, although I've already made that decision to some extent. But as a dentist, I always refer to the sleep doc. That's very important. And if they have severe sleep apnea, there are 3 categories. There's mild, moderate, and severe. Mild and moderate, typically, we've all been trained, physicians and the dentist, that an oral appliance may work, although even for me, that's not enough information. I can get into that later if you want. But if it's severe sleep apnea, that's if you have more than like 25 or 30 interruptions per hour, there's no sleep doc that's going to write a prescription for for an oral appliance. I have treated people that have completely given up on the CPAP on the CPAP. And so I have treated people that have AHIs of 70 or 80. We've gotten them down to 19. And then my ploy there is to get them back onto an APAP. Because remember, I mentioned earlier that the two together seem to work very well, and that has worked well. But that's something where you have to have the patient sign the treatment record saying, listen, you've said that you're not going to wear an oral CPAP. We're going to try the oral appliance, but it is not the end all. And it's usually hopefully heading to wearing both together. So it's not arbitrary. There are things that I look for. I like to do what's called a modified Mueller's maneuver. That's where the ENT sends a camera down through the nose into the airway, above the airway, and I like to preview what that thrusting of the jaw does. If the airway opens in that movement, then we know that the constriction of the airway is high up, nasopharynx, oropharynx. But if it doesn't, if that thrusting doesn't do anything to that little airway, which is sometimes the size of a tapioca straw. I mean, that's the diameter of the airway. It's frightening when you think about it. If it doesn't change anything, then I don't want to waste the patient's time, have them go through all the adjustment phases of the oral appliance, and sometimes have to pay out of pocket, $3,000-$4,000 for an oral appliance if it's not going to work. So it's not arbitrary. There isn't, it's not either this or that, and we don't want the patient to choose, because they always choose the oral appliance over the CPAP, and that's not necessarily a good thing. So there are kind of rules and parameters and protocols that guide us into where this patient should be, or how they should be treated.
I just wondered again how someone makes that decision. So, okay, that makes more sense. Well, very good. So, what's the best way for people to get your book? Is it on Amazon? Is it available everywhere? And then, if they want to see you, how do they see you?
Well, I would start with the book, and because it's just a 4.5-hour, 5-hour read. It was designed for people that are tired to read. Lots of bullet points and easy, just a quick way to make an assessment, a self-assessment of whether you should get a sleep study or not. So that's on Amazon. Just type in my last name or type in 8-hour sleep paradox. Give it a quick read, and I always recommend read it once, read it twice. Maybe make a copy of the bullet list that you've checked off, and then give it to someone else that you think needs it. And then you can always find me and send me an email if you want, by going to our website, and that is askthedentist.com. And there you'll find lots of information on sleep, references to the book, links to the book, and also lots of other dental stuff, lots of exciting stuff that's coming. New sleep tests, the whole oral microbiome, how it connects to the gut microbiome, which is getting its final due. It's a lot of attention now to how that affects our overall health, and the mouth is tied into that just completely and totally. It's amazing. So just those two, Amazon, Burhenne, type in Burhenne to get the book, and then the website, askthedentist.com.
All right. Well, very good. Well, Dr. Mark, thank you for coming on the podcast. I appreciate it.
Great. Thank you. Thanks for having me on the show. Enjoyed it.
You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and share it with friends. Thank you.